thank you all so much. I'm just amazed and delighted every day that I get to do this work, and especially that I get invited to share with classes and community groups. It's really one of the big things that keeps me motivated. And yeah, glad to get the introductions. Glad there's so many different people from so many different places in this class. So I put together a presentation on exploring immigrant health pretty broadly. And then in the second part of the time we have together, I'm going to hone in a bit on the work that CNNC does with our Immigrant Health Access Project. So I will start off. So Melanie already read a really long bio of me, but I've been doing a lot of reflecting, especially like with the research fellows, about kind of my positionality and how I came to this work and sort of the many phases that I've been through in getting to where I am now. So my pronouns are she, her, hers. I'm a white cisgender straight woman from rural South Carolina. I am not a recent immigrant, which is something I'm really aware of day to day. I always also sort of laugh when we talk about all immigrants and refugees here as newcomers or newly arrived, because I've worked with so many people who have been here for decades, and I myself moved to Greensboro 4 years ago and to North Carolina 10 years ago. So I think all these terms we use are pretty relative, and that's important to keep in mind. So the people who came before me were settlers and immigrants from Northern Ireland mostly, and Germany, and my family has been here for several centuries at this point, which again is something that I'm really cognizant of as far as what that means for power dynamics and that sort of thing. It's included a little bit about my family and sort of the class and educational background that we come from. I sort of say I didn't really have much of a chance of avoiding community work because of my parents and my grandparents. I also was really brought to this work through my upbringing. I was raised Presbyterian. I went to a little Presbyterian college that reminds me sort of a version of Guilford College in East Tennessee. So some similar values there. And all of this kind of came together to start shaping my path. Working at CNNC has made me a lot more interested in my own family immigration history. So one thing that my uncle shared recently is that my great grandfather on my mom's side, Oswald Bruckner, came from Germany to New York in 1881. And later the family moved to Fort Wayne, Indiana. So that's where my mom is from. And that's where this German family was located in the beginning. They were actually, as German nationals who had immigrated, they were required to register as enemy aliens during World War I. And the notable thing here, and here's the actual document, the document that they had to fill out declaring, I renounce my loyalty to the Kaiser, and I am not a polygamist, and I am not an anarchist, and so on. And Oswald, my great grandfather, was actually serving in the US Army while his mom was filling out this form saying, no, we're not a threat to you in this country. So I think for me, this illustrates how we tell a lot of stories, for example, about how especially immigrant groups who later have been categorized as white, right? How these categories shift. we tell a lot of stories, I think, especially about European immigrants, about how they came the right way and they assimilated, and somehow that's better than what's happening now. And not only is that not true, but it's a dangerous premise, I think, to follow. And so I've been really grateful to learn more about the nuances of my own family history and it's really helped me to think about how to get behind the stories that we hear in public discourse and how to kind of complicate the narrative a bit and think about who's afforded privilege and who is not in this system of immigration and resettlement that we have. So a couple more things about me and just how I arrived here. So Nalini mentioned to me that a lot of you are interested in, maybe interested in pursuing careers in immigrant health or community work. And so I would share a little bit about how I arrived here. So I mentioned, grew up in South Carolina, and I love this Google Map screenshot that I grabbed here that shows, here's the little town Union that I grew up in. Over here is a textile mill, Monarch. Over here is another textile mill, Buffalo. And then we've got the Walmart Supercenter. So this is a pretty good little snapshot of where I come from. This is kind of past and present of our economy, which is deteriorating. Latino immigrants were the only segment of the population that has grown since I left this town now over 15 years ago. So from there, I decided, well, I'll leave conservative South Carolina and move to East Tennessee, which was not as different as my 17-year-old self imagined it might be. But I was lucky to go to a college that was very internationally focused and social justice focused and had a lot of different opportunities to explore those things. Studied Spanish and nonprofit work. And so after my sophomore year, got to go to Mexico. So I worked with the Centro para los Adolescentes de San Miguel de Allende, Center for Adolescents in San Miguel, which is in Guanajuato, where many of our immigrants from Mexico in North Carolina come from. So I've met a lot of people here from places that I visited as a 19-year-old volunteer. When I graduated college, I ended up moving to Chapel Hill to do an AmeriCorps program called the Johnson Service Corps. During that year, I started working in substance use and mental health services, and I did a servant leadership training with the Second Breath Center, which used to be the Servant Leadership School in Greensboro. So that got me thinking a lot about a style of working with communities that is very much the style at CNNC. So without knowing it, I was sort of already on this path. So not only mentioned in my bio, I worked in a community food pantry doing food and rent assistance. I've worked with some radical mental health peer support groups, harm reduction, community mutual aid, and tenant rights through the Sacred Fire Unitarian Universalist Church. Eventually went back to grad school at UNC and found the Master of Social Work and Master of Public Health dual degree, which has been such a joy for me to explore this field. And finally, after I graduated in 2016, was fortunate enough to see that this immigrant health position was open at CNNC and managed to start working there in early 2017. So I say all of this just to say, when I graduated from high school, I had no idea that I might end up living here, doing this work, speaking another language. There's so many paths, and it's so exciting to know that. And working at CNNC has only reinforced that idea for me, just looking at my amazing coworkers. So that's one path. And now, enough about me. We're going to get into the actual topic. I like to start presentations with this idea: migration is our history, reality, and future. This is a quote from William Lacey Swing, who used to be the Director General of the IOM, International Organization for Migration, who interestingly is from Lexington, North Carolina, and went to Catawba College. So I love anything like this that demonstrates how close to home migration is, right? And I know I started out my career thinking, I'll go somewhere far away and help people there. And I've had to really shift that idea, that this is a universal occurrence, it's a universal experience, and it's our reality as human beings to grapple with migration. So, shifting to health access. The World Health Organization describes health as a state of complete physical, mental, and social well-being, not merely the absence of disease, which is pretty broad. However, in this country in particular, we think about access to health services, so personal clinical services that enable people to care for parts of their health. And so if we think about that level, access to health care involves 3 steps. So 1, you've got to gain entry to the system. 2, there's got to be a location where you can receive the needed healthcare services. And 3, in that location, ideally, you find a health provider you can trust and who can communicate with you, who can form a personal relationship with you that makes you feel comfortable and accepted enough to share your very personal information and needs. So let's talk about how this starts to come together with migration. 1, the health services have to be available. Am I in a place where they're available? They have to be accessible, and that's both geographically, the hours that they're available, transportation to get there, accommodation. So that means, is there someone there who speaks my language? Is there someone there who will take the time to understand my culture and to have conversations with me that acknowledge my experience and my needs? This gets into acceptability. Are these services acceptable to me culturally? Is this something that that fits with my beliefs, or that we can find some middle ground so that my healthcare is appropriate? Or do I feel very disrespected or offended by some of the things that are offered to me or pushed on me in this setting? Affordability. So we know that healthcare costs are one of the biggest barriers to people accessing care. And it's not only once I receive a service and receive a bill, but it's even beforehand. Do I even seek out the service when I'm afraid I will receive a bill so large that it keeps me from fulfilling my other financial obligations? It's one of the most frequent things that we hear in the Health Access Project. And so finally, the last piece is realized access. I think we hear policymakers often talk about access to healthcare. Okay, so access conceptually it's there. Everyone has access, it's the services are out there, but do they have realized access? Can they actually utilize the services in a way that responds fully to their needs? Can they participate fully? And so this is where these worlds of healthcare and the reality of migration start to get complicated, start to impact each other. So a few more things about U.S. healthcare. What's up with U.S. healthcare? I think this has been on all of our minds, front and center for the past year in particular. It's complicated, right? So unlike some other countries in the world, we don't have universal access. For most people, access to the health system is based on insurance. Most of us get it through employers, those of us who have it. Others may receive publicly funded insurance like Medicaid or Medicare, depending on a variety of factors. Many people are uninsured. Some can find insurance through the Affordable Care Act, which was a huge legislative change that increased access and continues to increase access to health insurance, luckily. But it's not perfect either. So we've got this mixture. We've got a mixture of public and private funders, public and private hospitals, health providers. The services are really fragmented. They're hyper specialized. So that means one person might have to go to 4 or 5 different specialists in addition to their primary care doctor just to manage various health conditions. And we see that a lot with some of our clients, especially older people or those with chronic conditions. Care is really expensive, as I just said. It's the #1 cause of bankruptcy in the United States, medical expenses, medical debt. And to be frank, the outcomes that we see in the United States are not, the cost is not justified by the outcomes. We're spending far more on care and seeing far less positive outcomes than other comparable countries in terms of level of economic development and sophistication in technology and that sort of thing. So we've got some issues. This is a great infographic that appears sort of small here, but I did include the link. So when you have the slides, you could go and explore that further. And it just has a few more data points about the system itself, as well as some of the other factors that influence health for immigrants and all of us. So, are personal health services enough? Are they enough for immigrant individuals and families to stay healthy? I'm going to take a look at some of the different factors, just putting it very starkly, that impact the risk of premature death. So the odds that we may die before the end of our natural lifespan. Healthcare services are here. So these are, going to the doctor, getting your physical, getting your screenings every year. It's estimated that that is about 10% of your risk to die prematurely. Genetics, about 30%. So, in my family, we have a history of high cholesterol. I've got a propensity towards that. So that's something that I can manage, but, I'm more likely than some other people to deal with that issue. Individual behavior, 40%. So what do I eat? How much exercise do I get? Am I sleeping? How's my stress management? And then social and environmental factors, 20%. So what we're seeing here is 90% of this is not related directly to receiving personal health care services. Now, certainly all of these things are quite related because the care we receive obviously can influence how our genes get expressed. Are we able to prevent certain things with the assistance of doctors or medications? Does our doctor help us figure out our individual health behaviors, recommend certain foods, certain exercise, other measures we can take? But this 20% social and environmental factors, that's pretty significant, right? And what I want to communicate is that the social and environmental factors really have a bearing on most of the rest of this, right? Of course, there's not a lot we can directly do to change our genes, right? We can't change our genes, but in fact, the social and environmental factors can influence how genes get expressed, right? If we think about toxic stress or historical trauma, sometimes these social factors literally do alter how our bodies respond to our environment and the health outcomes that are associated with that, if we think about epigenetics and that whole field. Individual behavior, I can make choices about how I spend my time and what I eat and all of that, but it's hard for me to make choices that my environment doesn't present to me, right? It's hard to make choices when they're not obvious to me, or when I don't have the means to carry them out. So healthcare is important. It's 10% of what keeps us from dying prematurely, and 90% of what keeps us from dying prematurely happens outside a doctor's office, outside a hospital, in the very conditions that surround us. So here's a breakdown of what we call the social determinants of health, these social and environmental factors that so influence every other part of our health. Economic stability, neighborhood. So I just think about, individual choices, individual behaviors. If I live in a neighborhood with no sidewalks and a high level of violence, no streetlights, no parks, am I likely to get out and take a walk every day? Probably not. So that is all connected. Education. If I go to the hospital and I get handed, 10 pages of discharge notes in English, but I neither read or write English, it's not going to do a lot of good, right? Like that document that's intended to help me follow up with my healthcare is essentially meaningless to me. Food and nutrition, very basic, a social determinant of health that is a real struggle, especially right now for many of the communities we work with in Greensboro. Community and social context, we think about all the time with immigrant and refugee communities we work with, this idea of being socially integrated, being welcomed into a community, into a society. This is literally the first part of our mission statement at CNNC, promoting access and integration. So am I isolated or am I supported? Am I able to engage in civic life, in community life, or am I excluded from that? Do I feel welcomed? Do I feel safe wherever I go? Or do I feel discriminated against? Do I experience discrimination? Do I experience hostility when I'm out in public or trying to access what I need? And then all of this too plays into the healthcare system. Health coverage, connects back to employment and income. Does my employer offer health insurance that allows me to access the healthcare system? Often not for the folks that we're working with. Are providers readily available? Sometimes yes, sometimes no. Language access, is that something that's part of my healthcare experience? Hopefully, but probably not in all settings. And so all of this comes down to really quality of care and then health outcomes. If these pieces are missing, and if I'm struggling with these other social determinants, it's not likely that I will have a consistently high quality of care, and that will lead me to be sicker, to have a shorter life expectancy, to spend more on care that may come too little too late, and lead to, as I say, early death or disability or just a lower quality of life. So I ask here, although I've touched on it, what's missing explicitly from this list that affects every single one of these things? And I should have said at the beginning, I welcome you to interrupt and ask questions, and otherwise, engage in conversation throughout the presentation. What may be missing here?
I would say like immigration status.
Yeah, exactly. So this article that I sent out ahead of time, right? Immigration affects all those other social determinants of health, as far as the access and opportunity that we have based on immigration status, but even the experience of immigration itself, like that set of experiences that people often go through, is now being proposed as a social determinant in itself. So I'll not acknowledge throughout that not every immigration experience is the same by any means. I think even among the people in this virtual room, we have so many different immigration experiences represented. Um, However, there is sort of a set of experiences, this almost complete realignment of daily life that the authors mention here, that's just intricately tied with every single one of these social determinants. This speaks to how being an immigrant, being categorized as other in this country, can limit behavioral choices and does, in fact, limit behavioral choices in many cases. Um, and I like this phrase, though not what it refers to. It places individuals in ambiguous and often hostile relationships to the state and its institutions, and even the local community, depending on how the community is oriented to receiving newcomers and what the social relationships are like that people experience. And so health services, of course, are part of all of this. They're such an essential part of our lives and a basic need, a basic resource. So we can think about three general stages of migration. So the migration journey has these three big stages that are more or less consistent regardless of whether people are forced migrants or voluntary migrants. This list is pulled from literature specific to refugee health, so more on the forced migration side. But just know that these stages, pre-migration, peri-migration, and post-migration, are consistent across experiences. So pre-migration, in your country or region of origin, what experiences you have before making the decision or being forced to migrate. Peri-migration, the experience itself, the journey or fleeing from your country of origin to the new country. And then post-migration, so coming to a new country, a new host country, resettlement country, what are the circumstances you find there that may impact your health? So pre-migration, in particular, when we're looking at people coming from lower wealth countries, conflict zones, malnutrition, rare diseases, lack of vaccinations, and poor reproductive care are often features that people may experience as far as health access and health challenges. When people are fleeing, especially as refugees, they're both fleeing from and often experiencing violence on the journey itself. So there's physical trauma, there's exhaustion just from travel and from being in this hypervigilant state as you're trying to survive. There's often sexual abuse along the journey. And this is difficult to talk about, but for example, many women and girls who present at our southern border from Central America are pregnant and often not by their own choice. And we know that sexual abuse happens also within immigration detention facilities, not just along the journey. Acute injuries from violence or from, again, just the stresses of the journey occur. Dehydration, broken bones, you name it. And all of this, of course, causes significant psychological trauma for a lot of people. Post-migration, so you arrive here, you're resettled, or you receive asylum, or perhaps you remain undocumented, but you're here in this country. Now you face the challenges of integrating here, trying to integrate, orienting yourself, maybe trying to go to the doctor for some of these other things that you've been holding on to that have developed over your migration journey to this point. But it's hard to get to the doctor. Food insecurity, housing insecurity, social isolation, these are all things that can be features of post-migration. Um, what I want to point out though is that a lot of these things can happen at any phase of this journey. So we sort of divide them into these categories and we assume certain things about countries of origin versus resettlement countries. But this idea of a triple trauma paradigm that we use a lot in mental health work, but also applies, I think, just more generally to the resettlement experience, the migration experience, is referring to the fact that refugees and immigrants often report that resettling, the process of resettling, is just as hard for them psychologically and health wise as everything else that happened up to this point. So I think those of us whose experiences are centered here in the US tend to think of people fleeing a very bad thing and that being the trauma. That's the traumatic thing, and getting here is a big relief and makes everything better. And that just isn't true based on the narratives that immigrants and refugees themselves bring to us. If we think about just the area of vaccination, I mean, that's what we're all talking about right now, right? So certainly some of the very basic vaccinations that we all need to receive as children, those may not have been available at all in a country of origin, but neither are they necessarily easy to access here. And of course, thinking about the COVID vaccination, I'm working with a lot of clients right now who would like to receive that vaccination. We are here in, the wealthiest country on earth, and they don't have access to that, despite being in categories that theoretically are eligible to receive it. So the arrow here just, shows that these experiences can happen at any point along the journey, but that particular experiences at any point can lead to certain health outcomes or certain risk factors. Any questions or any thoughts about what's presented here? Anything you would add? And it's okay if not. Let's go to the next piece. So let's focus in on that post-migration stage. So the people we're working with at CNNC are in the post-migration stage. They've resettled. They're trying to get oriented to life here in Greensboro, North Carolina. And so these are some of the barriers that we see people experiencing when they're trying to access care. So again, the way things are oriented here in the US in a really individualistic framework, we often focus on this interpersonal or individual level. So we say, well, immigrants don't understand how the health system works. Their beliefs are different. They don't have money to pay for things. They don't speak the language. They're just fearful. They don't trust the system. All of these things can be true. I think what really stands out to me among these things is the last one that I included, that there's a lot of shame and stigma that people feel in even trying to access the healthcare system, given that some of these other things may be true, especially finances. So they feel ashamed. Often I've had people say to me, I don't want to ask for help. Like, I want to be able to pay for this. I can't right now. I don't want to be a burden. I don't want people to think less of me because I'm asking for help. And so I think that's what gets very harmful about kind of attributing the problems to the individual and not looking over here to the other side and the other levels, which are societal and organizational. So one reason that people have limited financial resources for care is that they're legally barred from accessing health insurance, which is the main way we pay for care in this country. A reason that they may fear or mistrust the system is because we require types of documentation, or we require people to disclose information that puts them at risk of immigration enforcement action, right? ICE has conducted surveillance and enforcement operations near hospitals, even though they're not supposed to, for example. People are fearful, even if information is not shared from hospitals to Homeland Security because of HIPAA regulations, people are afraid that it will be. And often, there's enough suspicion based on actual violations of privacy and how those have impacted people that even when measures are put in place to protect information, the community simply doesn't trust that protection will be enforced to protect them. And all of these things also have connections to systemic and structural racism that's part of the fabric of our institutions in this country. So why is English a dominant language? We can go into a whole history of how that has come about. Why are certain cultural beliefs about health prioritized over others? Certain kinds of knowledge are prioritized over others. Certain ways of surviving are prioritized over others. All of this has to do with more of these structures and values underlying our social order. So then in the middle of these two, big level and small level factors, is the community organizational level. So what's happening here in Greensboro? Well, we're not a huge city, right? But our systems are still complex. It takes a lot of time to understand how things work or are supposed to work. Different programs have really different eligibility requirements. So although I might understand what's necessary to apply for Medicaid, if I try to apply for something else, the orange card or some other benefit, that might have a whole additional set of requirements that I need to provide. Once I am sort of into the health system, I have a primary care doctor, perhaps I may not always have transportation to get there. The clinic may not be open when I need it to be based on work schedule or childcare needs. I may get referred to a specialty care clinic where they don't provide interpretation. And so I need this care, but I am told I have to come up with my own interpreter. I might try to call my clinic to make an appointment, and I get directed to that confusing phone menu that's only in English, and I'm caught in this telephone loop that's hard to get out of without help. Capacity of clinics. So clinics, especially those serving uninsured populations, sometimes reach capacity. And so you may have all of these documentation requirements, you've done your application, you've gained access, but they may say, well, the first appointment we have for new patients is in 2.5 months. And if you've had untreated diabetes for 10 years, 2.5 months can make a huge difference, right? Like, this is time for things to get a lot worse before you're able to be seen. And unfortunately, people do experience organizational discrimination, interpersonal experiences of discrimination, providers getting frustrated about language or being frustrated about differences in understanding that they encounter when they're together in a healthcare visit or other situation. So all of these things, again, are sort of an interplay that are affecting people's access to care and then their health outcomes. So just as far as I want to go back just to barriers or experiences in the healthcare system, and see if anybody has comments or ideas that they'd like to share here, questions, your own experiences.
Um, I I think like the part that you were talking about, in terms of like the interpersonal individual level, the like shame and stigma, is something that I've seen in the participatory action research that I'm doing for my capstone right now. We're looking at like social determinants of health and environmental factors as it relates to childhood asthma. And there's been a lot of like resistance for parents to like want to talk about their children's experience with asthma or like their housing conditions, and other things like that because it is so personal, and it feels like they're being like shamed or stigmatized. So that's definitely something that I've noticed, like as a researcher, it's been really important to frame things from like a societal and policy and like access point rather than like an individual level. And I just like anything that you any like reflections that you have or like guidance around kind of that tension, I would really appreciate. And thank you.
Yeah, that's a really good point. I think practically, right, for any of us to like access any type of service, there are practically individual things we have to do. Like there are actions that we have to take in order to do that. Um, but right, these bigger factors make it easier for some of us to follow through with those actions than others. Um, I know one thing that I didn't necessarily expect to have to do in this job, but it's become like a real feature that sometimes is not very comfortable, is having to normalize the experiences that people are having of feeling discounted by the health system or feeling overwhelmed. Um, and this is not in the least to excuse the existence of those dynamics, right? This is not to say, well, this is just the way things are, so you've got to deal with it, but rather to say, you are not alone in feeling what you feel. Um, you know, a lot of people have a hard time paying for health services, and that is because of how the system is set up. It is not because of your individual failing. Um, it is not because you've done something wrong. Um, I'm trying to think of another example of that. I think just having the conversation that it's okay to ask for help. And I've said many times, in this country we sort of have this narrative that if you don't have money, you don't deserve to have help. And that's not how we do things in our organization, and that's not how we do things as a community here. Um, within the CNNC community, within the service provider community, working with refugees and immigrants. And so it's understandable why you would get this message. It's sort of all around us. And also just know that we all need to ask for help sometimes. And having access to healthcare is a human right. I mean, that is my professional and personal framework. And so those are the conversations I have with people. And they're really interesting conversations. Like people are very civically aware many times. Like they know exactly they know exactly what's going on. um, they have ideas about how it could be better, and sometimes like our community health workers are the only people they can talk to openly about it. So I think having open conversations about those dynamics, I think being able to normalize in the sense of, it makes absolute sense why you would feel stressed or sad or frustrated with this situation. And just know that you're not alone, and you did not create this. You did not create this situation. We're living in a system that's been created around us, and there are things that work and things that don't work. So we will figure this out together the best we can. Those are often the conversations that we have. And when there are opportunities to advocate or to connect people to, bigger community efforts, I try to do that too. Other thoughts based on the conversation so far?
Yeah, I wondered if
Hello. I was just, hi, I'm Catherine. I'm sorry, I came in a little bit late.
Hey, no
But I
problem.
was thinking we were looking at the policy levels and you talk about limits to hi, we're talking about limits to insurance and things like that. And a lot of times I'm from New York, and we see a lot of times, as you just said, there's the policies that are in place restrict them from getting the help that they need because there's so many, what we say, hoops they have to jump through just to even accessible, or deemed accessible to receive something. Does it make sense what I'm
Yeah,
saying? It's just
absolutely.
you know,
Absolutely.
it's,
Um, yeah, New York versus North
and
Carolina is
we
a
just, if we could just understand, you know,
yeah, I thank you for bringing that up.
yeah,
You're absolutely right. And
it's very, you see that all the time. You see people who need help, you know, they've just, but it's not that they can't get it.
yeah, you're breaking up just a little bit, Catherine. So I hope that I got most of what you were saying. But I was going to respond to that and say that North Carolina versus New York is a really excellent case study to see like how things can vary so much from state to state. New York has such a long history of engaging pretty proactively compared to a lot of southern states with immigration and with policies that are more inclusive. Not that any state is perfect, but I pulled up this chart. I'm going to skip ahead just a couple of slides. And this is now almost 6 years old, but just highlighting some of the federally funded programs like the ACA, Affordable Care Act subsidies for insurance, and also Medicaid and CHIP, which are the publicly funded insurance programs. So this is broken down by immigration status as to who is eligible to apply and when. And you'll notice, let me find an example. Okay, let's look at Medicaid. Okay, Medicaid for lawful permanent residents. So somebody with a green card. If you're 18 and older and you have a green card, you are not eligible to apply for Medicaid until after you've been in this country for 5 years. Okay. You see down here, this includes Cuban and Haitian entrants, Amerasian immigrants from places like Vietnam, Iraqi or Afghan special immigrants, so people who helped our military interpret and were able to come here on special humanitarian visas. Any of those people, you're a legal permanent resident, can't apply for Medicaid or most other federal programs until you've been here for 5 years. If you're a lawful permanent resident under age 18, you'll see there's a state option. So states can choose whether or not they will extend Medicaid coverage to you, as long as you meet other requirements, income, other categories. States can choose state to state. This is the maddening thing about our system, our federal government, right? That there's this overarching federal government, but states have so much discretion in what they can do that often it creates these huge inequities state to state for the very same segment of the population.
And can I just add, Kelsey, that the New York, North Carolina comparison is worthwhile because North Carolina is second to New York in refugee resettlement on the eastern
That's a really
seaboard.
good point.
So it's not like, oh, it's the South and we don't resettle as many. That's not true. So actually we're right up there. We're right after New York. So it's a really worthy comparison because it's apples to, it's almost apples to apples just in terms of refugee resettlement.
Yeah, and increasingly so. Like resettlement and immigration to the Southeast is more and more prevalent because it's cheaper to live here, right? It's close to the southern border. I mean, a lot of people end up here for various reasons. And you're right, it's not like people just started arriving yesterday and we just haven't had a chance to catch up. Like there are some pretty intentional, or at least like very partisan decisions being made that create these inequities state to state. So you can see some of the other things here. Undocumented immigrants, this is a good example. Okay, so let's look at Medicaid again. So undocumented immigrants and DACA recipients. Eligible only for emergency Medicaid. And in particular, in North Carolina, undocumented immigrants can get emergency Medicaid for labor and delivery, not prenatal care, not postnatal care, labor and delivery in the hospital. For certain, and this is all after the fact, you've got the medical event and then you apply for Medicaid after you receive the bill. So labor and delivery. What else am I? Certain ER bills, right? You go to the ER, you're having a heart attack, any care that they provide to actively save your life at that visit may be covered by emergency Medicaid if you're undocumented. They review your specific medical records, the specific procedures that were billed to determine that. And if you have end-stage renal failure, so if you depend on dialysis to stay alive and you're undocumented, every 3 months you can apply for emergency Medicaid to cover your hundreds of thousands of dollars in dialysis bills retroactively. So I've had people come to me and say, I've been going to dialysis for 3 months and I have $300,000 of medical bills and I need to apply for Medicaid or something. And that's a situation that you deal with. If you get a little better, if for some reason your kidney health improves and you no longer need dialysis regularly, then you don't qualify for emergency Medicaid anymore. If there's any other way for you to stay alive, you don't qualify for the Medicaid. So it's just a bizarre, to me, based on both my personal feelings and just professional training, like it's a really bizarre way to set things up. A lot of strange, perverse incentives, it seems to me. And again, this is different state to state in many cases, just depending on the regulations around the particular program. I'll mention DACA briefly because another article that I had you read ahead of time was about medical expenditures based on what people who are immigrants pay into the system versus what they receive from the system in terms of care and what gets expended on their care. And so the particular study looked at private health insurance only, and showed that even among people with insurance who are foreign born, they pay more into the system than is expended on their care. And those of us born in this country pay less into the system and have more expended on our care. And so the upshot is essentially immigrant populations sort of underwriting healthcare for the rest of us. And we can look at that in the public sector too, because immigrants are paying taxes. And in particular, if you're undocumented or if you're a DACA recipient, you don't receive the federal benefits that your taxes are paying for. The programs like the Affordable Care Act subsidies, Medicaid, Social Security, you're paying into these systems. You're receiving fewer, if any, benefits compared to people who are born here or people who happen to have a different status that makes them eligible for those services. So it gets very tedious very quickly. And I don't want to get too much into the weeds with specific policies because there's plenty to read about that. But just to highlight a few of the really complicated parts of this. And just related to this, right, we've already talked about how immigrants are not a monolith. This is not a monolithic group. This is a set of hundreds and thousands of experiences that differ in really important ways. And so one reason that we have this patchwork access to health and other federal or publicly funded programs is because our immigration system itself is so fragmented. So immigration pathways, again, this is very small, but even just the visual from afar gives you an idea of how many different steps and how many different paths there are potentially to come to this country, based on, do you have a family member living here who's a citizen or who can petition you? Do you have a job offer that might give you status? Are you a student and you can get a student visa, which technically does not make you an immigrant? That's a non-immigrant status. Do you have refugee classification? Could you claim asylum if you manage to get here in some way? All of these different considerations that impact how you may be able to arrive here, if at all. And once you do arrive here and have a certain status, as we've just talked about, that will impact in some really direct ways what you're able to access. The last thing I'll say about that is that we work with a lot of mixed status families. So it's very easy to be here and end up in a situation where different members of your immediate family can have different immigration statuses. So I work with a lot of parents who are undocumented. They may have some children who were born in another country and came here very young. So maybe some of them have been able to get DACA. They often have other children who were born here and are US citizens. So that means that each member of that family has a really different kind of health access profile. The kids born here may be able to get Medicaid, and that covers a lot of healthcare costs. The parents will not qualify for any federal assistance. The DACA recipient children will be able to get work authorization, but they won't be able to apply for Medicaid or get help through the Affordable Care Act. So it creates a lot of tension and frustration even within immediate families. Like, we're just talking parents and kids. So it's overwhelming. It's quickly overwhelming. I'll pause here again. So these are some composite stories that I put together. This is now sort of over the past 10 years or so. These are kind of characters I've constructed out of many, many, many different stories that I've heard over the years, just as another example of how many different experiences people are coming from. But I'll leave a little space for discussion or questions or just reactions or deep breaths, because I have to take a deep breath after I think about all of this for too very long.
Kelsey, I also just wanted to make you aware that this is about the time in class that we take like a 10-minute break. And so if you wanted to leave the slide up and let folks maybe process it while they take a break, go get some water, use the restroom, etc., I think that this would be a good kind of organic pause to leave folks at.
That sounds good. And I'll be here in case people want to chat one-on-one or in a small group, and we'll be back. I guess it's around 2:15, 2:17. I don't know what your clock says.
2:07. Okay, so maybe let's plan to all be back by 2:17.
Okay.
Sound good? Okay. See you all in a bit.
Hey, Kelsey. This is Allison. I just had a question because I remember at the community church of Chapel Hill Unitarian Universals, and I had wondered if you had ever crossed paths with them, being connected to like Sacred Fire and stuff.
Yeah, wait, so remind me again of the church you just said?
It's the community church of Chapel Hill. It's pretty close to UNC's campus. It's the Unitarian Universalist congregation there.
Okay. I'm trying to think. It's definitely familiar to me. I lived in the Chapel Hill area for about 7 or 8 years. I'm trying to remember if I actually ever made it to the community church. Reverend Nato Hollister is my good
Oh,
friend.
I know NATO. Yeah,
Yeah,
that's
yeah.
cool.
Yeah, so he actually is the person who got me into mutual aid and Sacred Fire, and actually just performed my wedding last fall. So he's a close friend that's been really influential for me.
My
Yeah,
mom
yeah.
was like on one of like the committees when he was like formally ordained in Unitarian Universalism. Like there was like a committee, so my mom knows him pretty well. But
Okay, I think we're at 2:18 now, so maybe we can resume, Kelsey, and um, I don't know if you wanted to create some space for discussion or questions. It looks like you still have a few more slides to get through. So yeah, whatever you feel comfortable with.
Yeah. So let me see. I'm gonna start the presentation back. I think there were a couple of other people who joined after I started, and I wondered, well, I know Catalina, and I think you've joined before, but Catherine, I just wondered if you wanted to give a quick introduction. No, Catherine's back.
Okay, I'm having trouble with my microphone, but yeah, I'm Catherine, and of course I was joining your topic is interesting to me because I graduated from Guilford with a public health degree, and I'm applying to graduate school. I want to do global health, and that's what my focus is. And I'm really more interested in policies than but I'm more the policies of society and how we can, and being one of those persons that help make decisions and how we lead things in our view with people and in terms of health, whether it's immigration or even as an African American, how we interact within the society. So
Absolutely.
that's what I want to do.
That's so exciting. I would love to talk to you more about grad school applications and where you're looking at and all of that. So yeah.
Or even as an African American, how
Yeah, we have some weird sound stuff going on. So again, I hope that I got everything that you were trying to say just now.
Catherine, your connection is a little bit idiosyncratic. So sometimes you come through perfectly clear, and sometimes you break up. Yeah, so I think we heard most of what you said, but if maybe the last couple of sentences you wanted to drop in the chat, that would be helpful.
All right. So I can move on to sort of the second phase of my presentation. I'm in the mind of like phases with vaccination, the second portion of my presentation. And then hopefully leave plenty of time at the end for discussion, or as I say, please feel free to open up conversation as we go along too. I did have some COVID content that I think we can come back to at the end if people would like to go more in depth with COVID. So I'll spend a little bit of time highlighting our program at CNNC that's primarily focused on health. So the Immigrant Health Access Project is one of the oldest projects at CNNC. It actually slightly predates the year that I have here, which is when the center was founded as a university center. But IHAP, as we call it, was in its sort of proto form in 1999, when it was funded for the first time by the local hospital association, now Cone Health Foundation. So since 2001, we've worked to promote equitable access to healthcare and all of the services related to that using the community health worker model, or lay health advisors is what we called them at the beginning. I, of course, have not been here for 21 years with IHAP. I've been here for 4 years, but many of the colleagues I still have at CNNC were some of the first lay health advisors, community health workers. So we've got this really rich tradition of that natural helper model. There are a few photos here highlighting some of our past outreach events and presentations when we could be maskless and very close together, and we look forward to doing that again when it's safe. So within that overarching goal of health access, we have 4 major goals specifically. So we want to try to ensure health insurance coverage or the Orange Card program are attainable for immigrants and refugees who are uninsured. The Orange Card is our local coordinated care network program that's considered the safety net for people who are uninsured. So if you're an adult and you live in Guilford County and your income is less than 200% of the poverty level, you are eligible to apply for the Orange Card, which gives you access to primary care, dental care, specialty care, and some other services. It's not insurance, but it's kind of the analog to insurance for those who can't access another option. So from there, we want to ensure access to integrated primary care. So we know that having a regular source of health care, like a primary health care provider, is a big predictor of your overall health status and trajectory health-wise. So we try to make sure that at minimum, people have a regular source of care that can provide follow-up and referrals and help people manage their health. So we quickly get into the social determinants of health and finding ways to address those. Couple different ways to talk about this. So among like direct service providers, we often talk about addressing the social determinants of health in terms of, well, we're going to make a referral. You can't pay your rent, we're going to make a referral. This is sort of addressing social determinants of health, and often it's the main day-to-day way that we're able to do this with our program. So finding the resources, connecting people to those. Of course, big picture, one-time rent assistance does not address the social determinants of health, that is lack of affordable housing and safe housing. So that's something that we always have in mind. And there's some bigger efforts at CNNC. You know, we work with different community groups, different efforts around those larger issues at the same time that we are working to help individuals get the rent paid so they don't get evicted. So just to make that distinction, those aren't the same thing. It's tricky. And they have to be both happening simultaneously. We have to be meeting the needs while we also address the bigger issues in collaboration with others. So that's a big part of our work. And of course, we've got to address many of these social factors as we help people find health insurance coverage and get to the doctor's office. Another big part of this is promoting health literacy, is what it's commonly referred to as. So I prefer to think of it as a dialogue with community members about their health beliefs, about health practices that they're used to. And then the other part of that dialogue is explaining how things are set up here. Like, what are the values and practices that are most common in our health system? How do you navigate the intersection of those? If you come from a place where you don't have clinics, like maybe you have a village midwife or a village healer, or maybe you come from a place like I've had clients from Cuba who were like, well, I could always just go to the doctor and it was free and I carried my medical record with me everywhere. You know, if you're coming from one of those places, either sort of extreme, and you come to the United States, it's a very different framework to navigate, right? So health literacy in terms of good understanding between communities and the health providers. And on the health provider side, trying to provide as much training and support as we can in how to provide culturally responsive care. Again, acknowledging that it's not up to the individual patient entirely to manage their health. It's not possible to do that completely on your own. So making sure that providers know how to be supportive and that they feel supported in being able to offer good care. So strategies for doing this. We do outreach of all kinds. Our community health workers are from the communities they serve. And so there are a lot of organic connections that they have, personal relationships, work relationships in other jobs, organizations they're part of, just neighbors and family members. So we do a lot of different kinds of engagement with people. Again, this past year during COVID, it's been tricky because we haven't been able to go out and make a home visit and eat lunch with someone while we chat about their medical bills, which is hard. But we've still been able to do a lot of connecting with folks by phone and by mail and by social media and finding other ways to stay engaged. I mentioned the health literacy. So we do offer some health literacy classes in collaboration with New Arrivals Institute. So they incorporate those into their English and citizenship classes on site. And then they've also done classes out at our community center sites through CNNC. We're even piloting a Zoom class with one community center with the Sudanese community, which is going pretty well. We offer some direct case management and care coordination services. So screening folks for their healthcare needs and then working to connect them directly to resources. That often involves dealing with language access and even providing direct interpretation services sometimes if they're going to places that just absolutely don't provide those services. We try to fill in those gaps whenever possible. And all of our community health workers are trained as interpreters. And then finally, the underlying strategy for all of this is just ongoing social support and advocacy. People know, even if we're in a situation where there's not a lot we can do to concretely change the external circumstances that they're dealing with, we find ways to reduce the harm of whatever they're going through, and we provide a listening ear. And we find ways to support them in advocating for themselves and also connecting them to bigger efforts that, where we can advocate for their access to improve as well. So those are our strategies. And on the right is our team. So these are all of our community health workers and my co-coordinators. Raouf is here in the middle at the top, and you will hear from him in a minute in a video. Von Kasur is my co-coordinator and refugee health coordinator. Pun Moyun, both Pun and Vong are from the Montagnard community, Jarai community. This is Kim Bahadur, who's from Burma and also speaks Nepali, so he works with Bhutanese and Burmese community members. Alice Hakizimana is from Burundi and works with Central African communities. Evelyn Rodriguez, who is from Puerto Rico, and she works with the uninsured adult dental clinic with Spanish speakers. Mayra Cedeño Caraballo is from Colombia, and she works with Spanish speakers in the community. And Lillian Levy is from Spain, and she also works with Spanish speakers. So a few demographics of who we serve. This is from the past 18 months, these numbers. And so it's been overwhelmingly people who identify as female. So about 2/3 women who often are, managing their households and the ones seeking out services for the rest of their families, and who just often tend to be more open and conversational about these things in the experience we have with our program. Again, this past year, especially, we typically see about half of our clients coming from Latin America. It's been over half this past year, which I think is just indicative of kind of the impact of the pandemic and access to resources, especially for undocumented people. But you can see this past 18 months, 72% of our clients were Spanish speakers. So that's why the majority, about half of our program staff is Spanish speaking. And then the remainder, it's very diverse. So split among Swahili, Kinyarwanda, Kirundi speakers, so Central Africans, about 15% of clients. Middle Eastern and North African clients, so Arabic speakers primarily. Southeast Asian clients, so Montagnard, members of indigenous groups from Vietnam. Some Vietnamese speakers, so like ethnic Vietnamese folks. We had one client from Laos this past year. Who am I missing? Yeah, Sudan, Burma, Vietnam. Central African countries include Congo, Democratic Republic of Congo, Burundi, Rwanda. And then again, most heavily people from Mexico, or a little over nearly 22% of our clients, and folks from Central America and South America as well. So Central America is making up the bulk of who we see right now. So El Salvador, Guatemala, Honduras, Costa Rica. Yeah, pretty amazing. We've served 740 unique people in the past 18 months. And that's pretty typical. So in any given year, we'll serve about 600 individuals. So I've alluded to the community health worker model. This is, of course, a role that I think pretty much every community and every society has had some form of this role forever. But in our current context, this is somebody who's a frontline health worker, who's from the community or has a really trusting relationship and close knowledge of the community served. They serve as links and intermediaries between health systems and communities, facilitate access, improve quality of care, build individual and community capacity, increasing health knowledge, and ultimately, a goal is for community members to feel comfortable and confident in navigating things, and asking for what they need. And hopefully, the end goal of that is for the health system to actually respond to what people know they need and what people can articulate that they need, that often the system just doesn't respond to. So we're looking at individual situations, but again, also looking down the line at how could we head off some of these huge challenges that are often so traumatic and difficult for people by making the health system better. So over on the right here, we have Kim, our community health worker, along with Dorothy Muhoro, who is a congregational nurse who works with Clone Health. They are out at our community center sites, the nurses, and so they're able to have face-to-face clinic hours, albeit masked and socially distanced these days. So nurses collaborate with our community health workers to see clients. And community health workers interpret and sort of facilitate the conversations and work with the nurses to get people what they need.
And Kelsey, can I ask that, is that picture in one of the community centers, or is it is it at the CNNC?
Yeah, so this picture was taken actually at one of our community centers that closed last year, Legacy Crossing over in Northeast Greensboro. So unfortunately, we were not able to keep that site open, but we have 3 other sites still that are similar to this. This one had that sweet mural though upstairs in the nurse's office. So this was Legacy Crossing.
Is that Glen Haven, Oakwood, and the newer one, the Community Enrichment Center that just opened up recently?
Yeah, exactly. So Oakwood is up on Highway 29, serving mostly Latino and African American community members. Glen Haven is up way north of downtown near Pisgah Church Road. And then Community Enrichment Center is over off of West Market Street near the Autumn Trace and Colonial Apartments communities. And 2 of those 3 have nurses right now. So Oakwood has not had the demand for a nurse to sustain that in a little while. Although we still have community health workers in contact with many of those residents. I can't remember if I put this on a slide anywhere, but I'll just highlight that our community health workers collectively speak 16 languages and are from 7 different countries. We have US born folks from immigrant backgrounds, people who resettled as refugees, people who came on various immigrant visas or spousal petitions. We have people from their early 20s to their late 50s on our team. We have moms and grandmothers and yeah, single guys and students. I mean, it's just a really exciting, like, dynamic, caring team, which means we can reach all kinds of people as well from different backgrounds. We have a really wide network of collaborators because this is obviously something that none of us can do on our own. So here are highlighted some of our closest collaborators, and there are many more. So I feel sure that some of you will recognize some of these names from your previous connections or current connections. And I have a couple of videos from 2 of our health workers. So this is Abdul Rauf Usman, who has been with us for almost 2 years. He's currently in Africa on his way to Cameroon to get married, which he's been waiting to do for a year. So we're so excited for him. He worked with International Organization for Migration in Egypt prior to resettling in the US. And he speaks Sango and Fula from Central and West Africa, as well as Arabic and French and English. So he's a powerhouse.
And he's actually coming to our class next week. Well, he's not. He's gonna Zoom in to the class next week.
Fabulous.
I didn't know he was traveling and getting married, and yeah.
He is, but he refuses to stop working. So I keep telling him I'm going to force him to take some self-care days when he gets back. So tell me if this sound does not work, Sonalini, but hopefully you'll be able to hear Rauf. Oops. There we go.
Oh, I don't think we can hear.
I can't hear it. Oh goodness. Okay. Let me see. Let me see if I can change a setting very quickly. Gosh, so I'll try one more time, but then if not, you can watch this after the presentation on your own. These are just they're 2 brief videos. They're about 4 or 5 minutes a piece. So let me try once more. Sharing sound. Okay.
I work with Immigrant Health Access Project. As a community health worker, I work with immigrant and refugee. I help them to access health. Most of my clients face a lot of difficulties or challenges to access health. For example, some of them does not speak the language, and other doesn't have transportation, other doesn't know where to go, or some of them, even they know where to go, they go to the hospital that has a specialist who does not provide an interpreter. As a community health worker, I help with taking appointment for my client, interpreting if needed, and also I help them in other aspects of their life. For example, if a client is facing a difficult time to pay his bills, I look for the resources and I work with the client, and we find the way to help them pay their bills. Also, if they are facing food, they are facing problem with having food, we help them with this. As a community health worker, I see our job is really essential because we are not just helping clients to access health, we are also helping them with the aspects of their life. I have a client that I will tell the story of my client at the end of the video. But other challenge that we are facing right now is when COVID came, most of the client doesn't have internet or they does not know how to use a telehealth. So that was a difficult for my client to access health because or from the culture, if they didn't go and see the doctor, then the doctor might not know exactly what they are having. So as a community health worker, we try to educate them and we try to help them to understand the system and what is best for our client. During this pandemic, we have people who are not insured and they have diabetes. I have one client that who diabetes and he spent like 3 months without his medication. As a community health worker, he called me. He told me he needs his medication and how can he get. He doesn't have insurance also. So we work with um, congressional nurse. We get him to see a doctor and also we help him with medication. After he got his medication, we help him to get orange card. And now he has orange card and we apply for him for Corn Health financial assistance. This is one of the stories of many of the stories that we have. Our client see us as a community health worker, not only a person who help them with the health to access health, but a person that they call anytime that they need. So our job is to facilitate and help client to adjust and to feel better in the country and also to help them access health system. We help with Affordable Care Act, we help with Medicaid, and also we help with Orange Card. Uh, in addition, we go and we interpret at the hospital and I do most of outreach with my client or the group of client. Most of the time when we are talking, what is Orange Card? What is affordable care? What is Medicaid? Those who are not unsure, they are those who are not insured can contact me sometimes and like ask them, I don't have insurance, I want to have insurance, or I need orange cards. So I work with them to apply for this. My opinion, we are not just a community health worker. I feel like we are psychosocial worker because we work with all aspects of life of the client. So this is few part of what role we are doing and the challenge that our client is facing. Thank you. Hello.
So get excited to hear more from Ralph. He is really fun to talk to and has so much good experience. You're really going to enjoy him. So one more video. This is from Lillian, our community health worker who started out as the CHW based at the adult dental clinic. And then just as the pandemic was starting this past year, she had expanded to a wider case management role. And so she essentially reinvented that role as she started it, and kind of created our model for remote work during the pandemic.
Hi, I'm Lillian. I'm a community health worker with the Immigrant Health Access Project. As a community health worker, I work directly with clients to help them access care. Some challenges to access insurance and healthcare are the language barrier, lack of transportation, legal status, as well as income level. When I work with clients, I make them aware of options and resources that are available to them depending on their particular situation, such as the Orange Card, Medicaid, or ACA enrollment, financial aid for bills that they may already have, connecting them with a nurse from the Congregational Nurse Program, helping them to obtain medication and accessing medication assistance program, helping them obtain transportation to an appointment, providing information about COVID testing locations, vaccinations, flu shots, mental health support, and interpreter support. Throughout the process, I follow up with clients and advocate for them when needed, and also try to get them to self-advocate as much as possible. I want to share the case of two different families with you. One family who has no access to health insurance or Medicaid had many medical bills from doctor visits and surgery. I worked with them to access financial aid as well as emergency Medicaid, and later guided them through the virtual Orange Card application process. They now have a medical home and an assigned primary care provider there, and their child has care at the Center for Children. In April and May, when this family faced hardship due to COVID closures and didn't qualify for any government aid or unemployment, I was also happy to have the chance to connect them with rent assistance programs. They received rental assistance, food, and supplies such as masks and hand sanitizer. Another family without insurance and without any access to care at the time had a case of COVID in their household this year. I was very grateful to get them support through the congregational nurse program. It was great for the mom to be able to talk to a nurse on the phone about her symptoms and the steps that needed to be taken. Working alongside other agencies, it has been great to be able to provide rent assistance and food for this family as well. She has now recovered and obtained an Orange Card, with which she has seen her primary care provider and has been referred to specialists as well.
So I love for y'all to hear directly from community health workers who are doing the day-to-day work of fielding calls all the time and supporting families directly in meeting these needs. And Ralph and Lillian are two extraordinary examples of that work. So one of my last slides to leave you with is just some ways that I see us moving forward with immigrant health and building communities that support the health of immigrants as an essential part of the community. So I think a challenge for us here in the United States is shifting from an individual to a collective mindset. So keeping in mind that health, while we think about it on this very individual level here, really is a collective effort. And so often the clients that we work with want to include their extended family and kinship networks in decision making, including community leaders, places of worship, other cultural organizations that they are part of. People don't care for their health in isolation. And so it's necessary to recognize that broader landscape of support that people are operating within. Part of that is acknowledging that we all come from different places with regard to what we think about confidentiality and who gets to make decisions. So we have some really strong laws in place here around patient confidentiality, which is really good in many ways. You know, we don't want anyone to be able to access information. And sometimes those things conflict a bit with people's norms about decision making in their family or culture of origin. So having open discussions about the laws and norms of healthcare in the US, you know, what providers are expected and required to do versus what patients are comfortable with, and trying to find creative ways, right, to meet patients where they are without compromising your own professional ethics or breaking the law in terms of sharing information and that sort of thing. But just acknowledging that the way we do things is not the only way, and that we need to have frank discussions about this. So I focused a lot in this presentation about the different sorts of trauma that people encounter. And I just want to acknowledge that that is a limited narrative. It's very real and important to acknowledge, but people going through trauma is not the end of the story. And so making sure that as we are working with communities and maybe researching or creating new models to intervene, that we're actually taking the time to really deeply listen to communities and what they're saying they want and need. If we are in a position to garner resources to put towards those needs or desires, and making sure that when we talk about tailoring interventions or approaches, that we're fully exploring what people's values are, health beliefs, how they spend their time, like just because I might go to the gym, I don't. Just because my friend might like going to the gym doesn't mean that I do. Maybe I prefer to go and dance somewhere or play soccer, football, or something else, So just acknowledging that there's many different ways to care for health. I talk with some of my colleagues from Latin America who are like, I go to a therapist now, but at home we just all like get together in the kitchen. Like all the women would get together in the kitchen and we would just cook and like chat and work it all out, So people have their preferences, and no matter where you come from, you have to acknowledge that. So there's a lot of policy advocacy that needs to be done, and that's over here on the right. But I also want to draw people's attention to the possibilities for advocating within your organization or your setting. There's nothing too small. So I talk a lot with organizations about how to improve language access, how to incorporate training and build capacity for serving immigrants and refugees, and making sure that your staff and your organization is fully informed and prepared and engaged in an ongoing learning process if you are intending to work with immigrant and refugee populations. I think, even at CNNC, we have a multiracial and multilingual and multi-generational staff. And we, in this past year, like so many other places, have been doing a lot of soul searching and self-reflection about how we are practicing equity or not, how we can become more anti-racist in our organization, and talking more about how that aligns with immigration to this country, which is steeped in the same sort of racial politics that's part of every other institution. So we can't assume, no matter what our background and no matter what organization we work in, we can't assume that we are not, how do I put this? We can't assume that we're excluded from practicing inequity, because we may be doing it without realizing it, and we may have internalized things that get expressed in ways we don't intend. And so I think I should have added sort of like equity and anti-racism work here in this advocating within organizations, but all of these are things to consider within your own context, ways to bring those ideas into your space. If you are interested in immigrant health or community organizing, engage in the wider community, attend events, volunteer with different community groups, just get to know people. I think for me, I am the kind of person who wants to jump in and like get things done. And that is, that's a facet of white supremacy culture in some ways. And I think just having to slow down and take the time to really get to know people on a personal level has been extraordinary for me. And it also makes the work better, when you're trying to get things done together. So just take the time to learn and get to know people. As I said, paying attention to the policy level. Right now, we're in this whirlwind of policy changes and huge shifts federally. We hope huge shifts that are starting to get underway. So much happening at the local level in terms of relief funding and who has access to what during COVID and beyond. So stay informed, pay attention to who your elected officials are, find ways to communicate with them, find ways to communicate with different working groups or coalitions on the local level who are working for these issues in really targeted ways. there might be somebody in your neighborhood. There is in mine. So connect with those folks and learn about what you can do. Again, policy is not separate from individuals. We see it play out every day. So keep learning. There are all kinds of resources out there. Know your rights trainings are really helpful. Bystander intervention trainings, those are readily available through a lot of different sources. Medical legal partnership is a great resource for helping individuals navigate policies and programs that impact their health. And then finally, and hopefully we have 3 minutes to converse at least, and I'll stick around afterwards too. Celebrate community resilience. I know within our team, as well as with the clients that we work with as clients, we are all the time celebrating birthdays and new babies and weddings and graduations and new jobs. And that is really important. That's kind of the point. We're trying to promote quality of life. And so to acknowledge these things with each other and to celebrate is part of what keeps us going and ultimately keeps us happy and well. I love the example of Siembra NC with American Friends Service Committee doing voter registration work, doing deportation response and community self-defense and partying while they do it, like bringing joy into really, really hard work and showing people their own power. I think that's a really incredible example of how you can bring that celebration into this work. So that's everything I've prepared. I would love to just open it up to questions, conversation. I realize I've used a lot of our time, Sonalini, but anytime we have left that people want to talk, I'm here to listen.
Yeah, thank you so much, Kelsey. That was like incredibly comprehensive and thoughtful. Thank you for putting together such a wonderful presentation for all of us. We do have a few minutes for question, discussion, points of clarity. Anyone want to?
While you're thinking, Sonalini had asked me to include some ideas for career development or future directions if you're interested in working in immigrant health. So I have a few things here that might get you started. One is our AmeriCorps Access project at CNNC, which places folks in both local organizations and places in other parts of the state working with immigrants and refugees. So check that out. Student Action with Farm Workers is another awesome organization based in North Carolina that does a lot around farm worker health and community organizing. So there are opportunities directly with them, as well as a really great job and job opportunity board that they have on their website. And then I'm a UNC public health alum, and so I receive all of the health behavior job listserv emails, which are frequent, but give opportunities for work all around the country and even sometimes internationally. And finally, I will be presenting on Friday with 4 of our community health workers at the Minority Health Conference that's organized by UNC. It's virtual this year, and there's still time to register. And the link is there.
If I could just follow up on something that you mentioned in your last slide around community resilience, and I really appreciate that point about when you're doing hard work or work that is hard, like introducing moments of joy and community solidarity is key to sustaining the work. And I wondered if you had other strategies that you've used personally to help you in the last 4 years in doing your work, particularly this past year. I cannot imagine it being an easy year for community health workers. Not that any other year is easy either, but this last year must have been particularly hard.
Yeah, definitely. So a few things. We started meeting weekly as a full group on Zoom, whereas before we'd had a monthly meeting with the whole team and then just lots of individual check-ins, which are great. But the beautiful thing about the team meeting weekly, at first I was like, well, we'll just do this for a few weeks until we don't need to anymore. And then everybody was like, let's keep doing it. Like, this is the only time I talk to other adults besides my husband, like, so that weekly meeting has become not only a super productive space for problem solving, but also just checking in, like, how are you doing? What's going on? Supporting each other with our mental health, laughing together, fantasizing about the food we're going to cook for each other one day soon. And so that's sort of collectively some stuff that we've done personally. I have a yoga and meditation practice, which is really key for me. Before the winter hit, I was also like taking a walk every morning, which is wonderful. So now that the sun shines back, trying to get outside. And just like checking in with clients about that too, just saying like, hey, have you taken a walk? What are you doing to relax? Is there something we can talk about, even though things are stressful right now, that would help you carve out even a few minutes a day for that? So those are a few things.
Great. Thank you. I see we're at time. Thank you for your kind offer, Kelsey, to stay back for a few minutes. But I don't want to, keep people if they have other commitments. So once again, will you all join me in thanking Kelsey for her time with us today? And this was great, Kelsey. Thank you so much.
Great.
Your hands.
Oh, yes. And I see the comment in the chat. Yes, I'll be sharing my slides and hope that any of you feel welcome to email or call me whenever, and I'll get back to you as soon as I can. Thank you so much. Take good care. Bye. Thank you, Melanie.
Thank you, Kelsey.
This was so much fun.
No, this was